Hello, and welcome to my presentation on mental and physical well-being interventions, post-acquired brain injury, commonly known as an ABI. It could happen to anybody. It is no respecter of age, but I hope it never happens to you. This research presentation looks at stroke survivors and their perceptions and belief of available interventions post-ABI, in particular counselling, to assist their physical and mental well-being. There were 3 of us involved in the research, but our dissertations were done individually, and I undertook to do specifically the mental and physical well-being interventions post-acquired brain injury. My presentation will look briefly at the background, the methods used, how we recruited participants, the results, which unfortunately are incomplete due to the fact that I haven't finished my dissertation, and a discussion as to what is available and not available in regard to assisting ABI survivors. Who am I, and why am I reading for a Master's in Counselling? I'm Angela Grimshaw. I'm a stroke survivor with an ABI. I'm in my final year at Bangor University. Yes, I found it extremely challenging and a struggle, and I have made it to the end. I have a keen and passionate interest in interventions available post-ABI, in particular to both their mental and physical well-being. My research focuses on stroke survivors with an ABI, availability of counselling as an intervention post-ABI, and the belief as to it would have been beneficial if counselling had been offered. 1.4 million on average attend hospital annually with a head injury. Approximately 453 of those result in an ABI and are admitted annually to hospital. That is 531 per 100,000 of the population, and staggeringly it is the most common cause of death in 1 to 40-year-olds. I want to look at the classification of an acquired brain injury. Peter states that a brain injury is due to an external force. That is correct in some way, but is a little misleading. So, what is an acquired brain injury? An acquired brain injury occurs after birth, so one isn't born with it. Under an acquired brain injury, there are 2 classifications. The first is a traumatic brain injury, which is caused by an external event, such as a road traffic accident, falling off a ladder, and the non-traumatic brain injury, which is caused internally as a result of either a stroke or a brain infection or an aneurysm. But both are classed under an ABI. You're very lucky in North Wales to have the North Wales Brain Injury Services, which was brought via the government in 1995 into existence and specialises in treatment and rehab for acquired brain injury survivors. My research presentation and dissertation looks at 1 question with 3 hypotheses. My research question is: how do ABI patients perceive the availability of mental health support post-ABI? Hypothesis 1. A significant proportion of adults over 18 with an ABI will not have been offered counselling. A significant proportion of adults who were offered counselling will state that it was helpful, and B, that a significant proportion of adults over 18 who were not offered counselling will state had they been offered counselling, they would have benefited from it. Hypothesis 2 is older adults will report fewer offers of counselling than younger adults following a traumatic ABI. A. For those who are offered counselling, there will be no age difference in those who found it useful and those who did not. And B. For those who are not offered counselling, there will be no age difference between those who believe it would have been beneficial and those who believe it would not have been beneficial. Hypothesis 3. Participants who received counselling will report higher current levels of well-being than participants who did not receive counselling. Possible cognitive effects as a result of an ABI. Planning an organisation is quite often problematic for somebody with an ABI. Problem solving is also quite often problematic. Speech loss is quite frightening when it happens when you've always had speech. Memory loss, usually the short-term memory. And judgment, sometimes your judgment can be out in a way such as just crossing the road. A person with an ABI might not be able to gauge the distance correctly. Furthermore, analysing information or processing information in and out is quite often problematic for a person with an acquired brain injury, in that taking information in, thinking about it and then wanting to reply is quite often hampered by a delay in the brain. All the above can have an effect on behaviour of a person with an ABI. It can result in extreme frustration and anger, and therefore counselling to deal with these problems is very important. Methodology. This research and my dissertation looked at recruitment, initial contact with participants, data collection, the use of media, the use of an online questionnaire, and 3 individual case studies. Headway and the Stroke Association, both of which are charities, were approached in regard to access to participants to take part in our research. We also looked at Facebook and Twitter and put an advert on there requesting people with an acquired brain injury to sign up to the questionnaire. The questionnaire contained an information sheet right at the very beginning. It detailed what the study was about, signposted to organisations such as Mind and the Samaritans, and very importantly addressed the issue of consent, which when doing this sort of research it is ethically very important that you have gained consent and the people understand exactly what they're entering into. All participants were explained that they could withdraw from the research at any time. Having once signed the consent form, people were then able to access the online questionnaire. We received 31 responses but had to exclude 18 of them for incorrect filling in of the questionnaire form. So we ended up with a small study of 9 females and 4 males. All participants were volunteers and had to be over 18 years of age. The questionnaire first looked at demographics of the participants, such as age, gender, ethnicity, and home, where they were born and where they lived. Did they have a diagnosed disability? Did they have a diagnosed mental health problem? What was the cause of their acquired brain injury or traumatic brain injury, and when it first occurred? It also looked at the impact of an ABI on a person, and particularly had a 4-point scale in regards to how they immediately felt post-ABI. And it ranged from not at all to a lot of difficulty in their everyday life. There were 11 questions, and examples of which were memory, attention, concentration. There was also a mental health support questions, such as offer of counselling, the time period post-ABI. It further asked when they received their first counselling session, the number of sessions attended, how often they attended, was it helpful, would it have been helpful if they had been offered counselling, was it private or NHS, and what support should be provided did they feel post-ABI. A 5-point Likert scale was used to gain the experiences on feelings and thoughts within the first 2 weeks of an acquired brain injury. And the Likert scale consisted of 5 points, which varied from none of the time to all of the time, and it contained various questions on how optimistic they were about the future, and various other questions in regard to their mental health and well-being. It's difficult currently to assess the results with any meaning, as my dissertation is still ongoing, and the fact that there were small numbers, so the analysis is incomplete. However, looking at my initial study, I could see that the leading ABI contributor was a stroke, and secondly, a head injury. I can see at a very basic level that the number of people who were offered counselling was virtually nil. Out of the 13 participants, 11 were not offered counselling. And that those who were not offered counselling thought that it would be helpful was 9 out of the 13. And those who had not been able to access counselling at all were 8 out of the 13. Although this is a very limited assessment of the results so far, I am limited in the fact that my dissertation and research is incomplete at the moment. There is substantial evidence out there to suggest that a rehabilitation prescription should be available and that a quality trauma discharge programme would be advantageous and it would be cost effective. However, it is inadequate at the moment in the UK, and it varies across areas in the UK. Living with a person with an ABI or being part of their life quite often causes stress on the carers, family members, partners, children. So therefore a quality discharge programme would be appropriate. North Bristol National Health Trust Hospital, in particular South Mead Hospital, created a quality trauma discharge programme. It was a comprehensive discharge package based on the RED project from Boston, USA. The quality trauma discharge programme from Bristol NHS has proved to be very valuable in that it contains a detailed discharge consultation with a trauma practitioner, counselling with the pharmacy, an after-hospital care plan, an AHCP, post-discharge follow-up and patient-controlled electric version of the AHCP. The programme has resulted in a 20% need for a patient to see the GP within the first 30 days of discharge, that the patient and carer's satisfaction has improved in the system. An unexpected benefit is the patient's safety and avoidance of harm, but via signposting patients to care, messaging and telephone helplines. This quality trauma discharge programme has been introduced into Wales in the last few months. Thank you for watching. Hopefully you've taken from this presentation that an ABI can happen in a flash of a light and that it is life-changing. So always practice some me time, because stress can bring it on just as much as a traumatic incident. Take care and keep well.